Our next speaker is Professor Chandu de Silva, Senior Professor and Chair, Department of Pathology, Faculty of Medicine, University of Colombo. His association with dermatopathology is about 35 years, and he has been involved in sorting out difficult dermatohistopathology problems for us over so many years and has a vast experience in dermatopathology. And today, he is going to speak on one of his pet topics, I think. So over to you, Chandu.
Thank you very much, Ganga. Good morning. Actually, Jayamini scared me so much that I have forgotten what I was going to say. I'm not used to these clinical pictures, Right. I'm going to pose a question to you, and you're actually going to provide the answer at the end of this talk. Okay? So you will be the jury, and the question that I'm posing is, hypopigmented mycosis fungoides, is it a completely different lesion from classical mycosis fungoides? Okay? I also made this presentation to the College of Pathologists, so I will just skip through the earlier slides because telling you about the clinical features of mycosis fungoides would be like taking coal to Newcastle. Okay, right. So mycosis fungoides, the WHO defines it as an epidermatrophic primary cutaneous T-cell lymphoma. Epidermatrophic because the cells are going into the epidermis. And it's characterized by these small to medium-sized T lymphocytes with a convoluted cerebriform nuclei. And it has patches, it develops through patches, plaques, and tumors, and there are some variants like the follicular trophic mycosis fungoides or pagetoid reticulosis, granulomatous slack skin, entities that we hardly see actually. I mean, we have seen one case of granulomatous slack skin. There was a drummer, I think, once. And so these are not common. But the classical mycosis fungoides, as you know, evolves through patch, plaque, and tumor stages. Okay, so I'm not going to go through these because you have seen these, the plaque stage and the tumor stage. Now, there are some unusual clinical presentations of mycosis fungoides, and actually hypopigmented mycosis fungoides is not recognized as a separate entity in the WHO classification. It goes as a clinical variant, okay? And rarely we do see solitary lesions, which will be very difficult to sort out. And the other lesions are also very rare and we hardly see them. So these pictures were kindly provided by Chalukya, the typical hypopigmented mycosis fungoides. So now we come to my task, which is the histological diagnosis of mycosis fungoides. This can be a challenging task. The diagnosis is based on architectural and cytological changes, but the problem is these changes might be quite subtle. And as you know, if you take 3 biopsies from 3 sites from the same patient with mycosis fungoides, about 2 of them might be normal, and it's the third one that where you can make the diagnosis. So this problem is well known to us. Basically, there are 2 arms to the diagnosis. There are the architectural features. What are the architectural features? Variably dense lymphocytic infiltrate in the papillary dermis, but they don't stay in the dermis, they go up to the epidermis, and that is called epidermatrophism. Now, epidermatrophism or exocytosis can also occur in a lot of other skin diseases, okay? But the clue here is that there is cytologic atypia as well. And so it's a combination of the architectural features and the cytologic features. Now, what do we mean by epidermatrophism? There are 2 types of epidermatrophism actually. It's not coming on. Can you see the arrow? No, no. Okay, so linear epidermatrophism means at the dermoepidermal junction, you get these lymphocytes, and can you see they are surrounded by a vacuole, which is a very characteristic feature. And if you look closely at the lymphocytes, they are atypical because they are enlarged with those convoluted nuclei. Spongiosis may or may not be present in Mycosis fungoides. The earlier teaching was that if there is spongiosis, it's unlikely to be Mycosis fungoides. That's not true, because you can get spongiosis in Mycosis fungoides, but the clue is that in Mycosis fungoides, you will get the epidermatrophism even in areas where there is no spongiosis. Whereas in dermatitis, the lymphocytes will always be in an area where there is spongiosis. And the Portria microabscesses, now actually when we did the study that I will talk to you about, we searched to see what is the definition of a Portria microabscess. It's not given. How many cells should you see in a vacuole to call it a Portria microabscess? So some studies have taken it as over 4, but we in our study took it as over 3. Okay, so it's a collection of these atypical cells in a large vacuole. Now, to diagnose Mycosis fungoides, you have to use thin sections where the cells will be visible. The cell morphology will be visible very clearly. And sometimes, if it's really difficult to recognize the atypia, I will focus it under oil, and then it is easier to diagnose. Another clue is, even in an ordinary skin disease, you can get lymphocytes, which can look a bit atypical here and there. But in Mycosis fungoides, these atypical cells always occur in a group. And in the dermis also, you will get atypical large cells. Then there are some additional features which are described in the books, like papillary dermal fibrosis, or like a wire loop lesion, like a wire loop capillaries in the papillary dermis, or you can get like fibrosis occurring around the capillaries, and dermal mucinous change, but we don't make use of these features to diagnose Mycosis fungoides. Now, these cells are T helper cells, which are usually CD4 positive and CD8 negative. All T cells are CD2 positive, 3 positive, 5 positive, but because it's a lymphoma, they may drop some of these antigens. A few might show a CD8, CD4, 8 positive, 4 negative phenotype, with the T receptor gamma being positive or negative. This has been reported especially in the pediatric form of Mycosis fungoides. Okay? Now, I wish to make a point here. Do you need immunohistochemistry to diagnose Mycosis fungoides? Actually not. If you see the characteristic atypical cells, and if there is epidermatrophism, and if the clinician thinks it's Mycosis fungoides, it's not necessary. Okay? But then why do we do it? Sometimes we may not be sure whether the cells in the epidermis are actually lymphocytes or whether they are squamous cells with pycnotic nuclei, in which case you can do a CD3 stain. Okay? Now, for routine diagnosis, it's not necessary to do CD4 and CD8 stains, but I will come back to that later on. Now, don't confuse the CD8 positive lymphocytes in the rare forms of Mycosis fungoides with another disease called primary cutaneous CD8 positive aggressive epidermatrophic cytotoxic T-cell lymphomas. These are very aggressive conditions which come with multiple papules and ulceration and necrosis. They may drop some of the T-cell antigens. This is not a variant of Mycosis fungoides. It's a completely different disease. Luckily, we don't see it much. So you all also would have experienced that you see the two types of mycosis fungoides in this country, the classic hyperpigmented type or the erythematous type, and there is the hypopigmented type. And from our experience, we thought that hypopigmented mycosis fungoides seems to be commoner, anecdotally. And therefore, I thought we'll pull out all our slides and compare hypopigmented mycosis fungoides with the classical mycosis fungoides so that you can answer the question at the end of the lecture. Okay? So now I'm going to present it. This was actually published in the Journal of Cutaneous Pathology last year. Okay? This comparison between hypopigmented and the classical mycosis fungoides, and this is actually the biggest study of hypopigmented mycosis fungoides to date in the world, but this is also with a very limited amount of cases. Okay, so what we did was, luckily all our cases are diagnosed. The people who come to our MDTs will know the diagnosis of mycosis fungoides is made only after the MDT, if the clinician is also quite certain that it is mycosis fungoides. So all the cases that we used for the study were cases which were clinically confirmed to be suspicious, and also there was a consensus diagnosis at the MDT. So there were 87 patients after dropping. Now, this was a retrospective study, so obviously we had to use the request forms. And again, I'm very thankful to you all because you provide such good details in the request forms, like, describing the lesion. So we were able to sort out the hypopigmented ones and the hyperpigmented ones. But where it was not written, we did not include them in the study. Okay, so that is why after 5 years we had only 87 patients. And as I said, all of them, these are not cases where you thought of something else and we thought of mycosis fungoides. These were cases which initially you thought was mycosis fungoides, but there was a consensus diagnosis. So there were 76 cases of hypopigmented mycosis fungoides and only 11 cases of the classical type. And straight away you can see the immensity of the problem, because hypopigmented mycosis fungoides seems to be the commoner type in this country. When we compared, the mean age for hypopigmented mycosis was 33 years compared to 42 years for the classic group, but this was not statistically significant. Okay, but you'll be interested, Germany, all the patients below 14 years of age had hypopigmented. There were no cases in our series with the hyperpigmented form. There was a significant female predominance with a p-value of 0.04. You can see in hypopigmented mycosis fungoides, it's commoner in females than in males, whereas the classic type is commoner in males more than females. And also, a higher proportion of patients with hypopigmented mycosis fungoides presented in the patch stage. Actually, all of them presented in the patch stage. Okay, so obviously it was statistically significant. Now, we analyzed the histological features very carefully. We looked at the dermal infiltrate. We looked at the lymphocytes at the dermoepidermal junction, which is called basilar epidermatrophism. We looked at superficial epidermatrophism, which is the cells going into the epidermis, Portria microabscesses, the degree of ATP of the epidermal lymphocytes, and degree of ATP of the dermal lymphocytes. Okay, and we gave a score of from 1 to 3 for each of these. I'm not going to go into details of that. But what we discovered was that the dermal infiltrate is much less in the hypopigmented mycosis fungoides. It tends to be perivascular, and actually you might misdiagnose it as vitiligo or leprosy or eczema because there is not much of an inflammatory infiltrate. And this has been reported by others as well. if you look at this, can you see the cells are mostly at the dermoepidermal junction, and the dermal infiltrate is actually very sparse. Here again you can see some atypical lymphocytes. They seems to be having a party at the dermoepidermal junction without social distancing, okay? But there is hardly any cells in the dermis. The cells that you see here are actually either fibroblasts or a little bit of histiocytes. So the dermis seems to be empty, but there is a lot of activity going on in the epidermis. So, but overall, linear and superficial epidermotrophism was similar in both types. Portrio microabscesses were less in the hypopigmented one than in the classic Mycosis fungoides. So all the ones with the classic Mycosis fungoides had good portrio microabscesses, but in hypopigmented it was less. But the degree of atypia in the epidermis was similar in both forms. But atypia of the dermal infiltrate was more in the classic form than in the hypopigmented form. Okay? And these are some examples of, this is an example of huge portria microabscesses. Okay? So what are we talking about? We are talking about histology where there is an atypical infiltrate in the epidermis, but hardly any infiltrate in the dermis. And also, the atypia in the epidermis is the same in both, but hardly any atypical cells in the dermis in the hypopigmented type. Okay? So, the hypopigmented type, if you are not careful, might be easily missed. And because of your clinical suspicion, we sort of go into this in depth and look at it, but otherwise it's quite easy to miss it. Then in a few cases we did the immunohistochemistry and they were all positive for CD8, okay, with 94.74% showing a CD4 negative, CD8 positive profile, okay. However, all the cases of classic Mycosis fungoides in this study were also CD8 positive, which is unlike the what we know about classic Mycosis fungoides. Okay? Now, the better way of diagnosing this would be to do T-cell gene rearrangements, but that could not be done. So, just two examples. You can see the infiltrate there at the dermoepidermal junction. You can see these cells are CD3 positive, okay, but very few of them, and most of them are CD4 positive as well, okay. So that is the classic Mycosis fungoides. You can see there is quite, if you look at this, there is quite an amount of lymphocytes in the dermis as well. That's the classic type. If you take the hypopigmented type, hardly any infiltrate here. None of the cells in the dermoepidermal junction are CD4 positive, but you can see how they light up with the CD8 stain. Okay? So in summary, hypopigmented Mycosis fungoides tends to occur at a relatively younger age and in females. The females was statistically significant. Majority of lesions present in the patch stage, and as you know, they run a very indolent course, remaining in the patch stage for, of course, we didn't have follow-up in this. The dermal infiltrates are mild and dermal atypia is not severe in the hypopigmented type. Epidermotrophism and epidermal atypia are present, but they have to be carefully assessed. And CD8, they are CD8 positive and usually CD4 negative. Okay? So now the question is, hypopigmented Mycosis fungoides, is it a different clinical entity from classical Mycosis fungoides? We are talking about a disease which is commoner in a younger age group, markedly predominant in the female population, patch stage, mostly epidermal, hardly any dermal at all, to the point where you might even miss the diagnosis, and CD8 positive as opposed to CD4. So can I see a show of hands from the experienced and new dermatologists? What do you think? Who thinks that they are the same disease? And who thinks they are different? Yeah, you know. So the world literature does not acknowledge this, okay? And this is, we have to show this. When I presented this in India, they were also not, they had not gone into this in depth for some reason or the other. But of course, this study was only a retrospective one without, clinical thing. So actually, they asked us whether what happened to these patients, and we said no, it's a pure histopathology article. That's why it went into a histopathology journal. But there is a lot to be done. Now, I will ask you another question. How many of you think that this might not be a lymphoma, might be just some other entity where we are, misnaming it as a Mycosis fungoides, going on the, Shalukya thinks the same. Yeah, lot of hands, So, I mean, are we labeling patients unnecessary as Mycosis fungoides when actually it might not be a lymphoma, and especially children, the parents are so worried when you say that, but they go to the internet and they look, and you are labeling that child forever with the diagnosis. Now, for them, it's cancer. So, should we, do a good multi-center study and prove, and maybe call it, hypopigmented lymphoproliferative disease or something like that, without calling it hypopigmented mycosis fungoides. So my acknowledgements are to all the dermatologists who send their cases. Quite a lot of them are actually in the audience. Ganga, Indrani, then Chalukya, Janaka, Jamini, there was a few of your cases as well, and some from the outstations. So I'm very grateful to you, because actually, other than diagnosing, it's because you send that we see the difference. Otherwise, we would know. This study was actually done by Dr. Dinesha Jaisingh, who is a senior lecturer in the department, as a MD project. And this is why I was telling you, trying to encourage them to do dermatopathologist. Now, if a MD person from your side did the clinical bit, we could have combined and had a better paper. I'm also grateful to Dr. Karuna Disanayaka, who gave her cases from NHSL. So thank you very much, and stay safe.
Thank you, Chandu. I like to ask now to decide whether this is lymphomatous or not. Now, will the gene rearrangement studies be of help?
Ideally, we should, okay? Because to put it that now even the WHO, okay, I'll answer it in a different way. Gene rearrangement may point towards a lymphoma, but it's not an absolute thing, because even mosquito bites can show a little bit of gene rearrangements. Okay, so it's not an absolute diagnosis. The way to do it would be to show that when these patients are followed up for about 5 years or 6 years, nothing happens to them. And from a clinical point of view, say that, you should not label this as lymphoproliferative. That has happened with other diseases also, lymphoproliferative diseases, where they took off the lymphoma tag and started calling them lymphoproliferative, just so that the term lymphoma is avoided. Yes, yeah. Yeah. Good. Yeah. Yeah. Yes. Yes. Mm. Mm. Good. Did they progress? Did they progress? But actually, the children's ones, when you look at them, it's quite scary because it's very scary. Mm. Is it that the females are more concerned from a cosmetic point of view when they are coming? And so the yeah, yeah, they do hairstyles before weddings. Yeah, we don't use that. We don't use that. Yeah, now that's another big topic, you know. We have not gone into this at all, no. Pityriasis lichenoides chronica, whether, so that's another huge topic by itself because the ones that we are calling pityriasis lichenoides chronica are those really like, you know, could these two diseases merge? You know, if the hypopigmented one is not a lymphoma, is it just another, you know, sort of very aggressive form of pityriasis lichenoides chronica? So, okay. Have you had cases where you've been following up PLC and it turns someone then suddenly calls it on a next biopsy mycosis fungoides? Yes. But have you all seen that? You have seen, okay. Other thing that we keep on saying is, you know, the now you're saying 3 biopsies. Now we also like when you send a lot of biopsies, 2 are like one might be completely normal. One you might see a little bit of cells. Because the third one is definitely mycosis, we know that it is. The second one is also probably mycosis. But if it came on its own, I would never diagnose mycosis on that second one. You know, so it's very interesting. Another thing I wanted to go back was, can you remember I said now our classical one is also CD8.8 positive. Only thing the numbers are not enough, you know, just 19 cases. So we have to do it on a larger scale and see whether it is a problem with the pigmented skin. Yes. acid, that's right, yeah. And also in the children.
Thank you, Professor Chandu, for that very educative